Thank you so much, and I welcome everybody who has joined in. The talk today is about lymphedema, and we all know that uh, the foremost treatment of breast cancer is surgery, and which is generally followed by chemotherapy and radiation. And lymphedema, which is just swelling of the hand where the surgery is done, or the ipsilateral hand where the surgery is done, on the same side, marks a very important quality of life compromising event. But there are a lot of facts and fictions around lymphedema, and that is exactly what I'm going to discuss today. So we know that lymphedema is a feared complication of cancer treatment and one that negatively impacts survivorship. The incidence of breast cancer related lymphedema ranges from 6% to about 70% in some studies. And but lymphedema may be more commoner or maybe underreported morbidity. Many people tend to accept it. However, overall, 80 to 90% patients who will develop lymphedema will do so in the first 3 years of their treatment, but the rest persist years later as well. And the remaining 10 to 20% will develop lymphedema at a rate of 1% per year. Unfortunately, there's no standard guideline for its diagnosis and assessment which exist, and that is the reason why there are so many facts and fictions around the lymphedema and its management and the counseling which is required for these patients. One of the most common myth or fiction is, can patients exercise or lift weights after surgery? As a matter of fact, the evidence suggests that this should be actually encouraged. Patients should start slowly with light weights and few repetitions, increasing gradually, but ceasing if it is painful. There was a large randomized trial which was weightlifting for women at risk for breast cancer related lymphedema, and it concluded that in breast cancer survivors at risk for lymphedema, program of slowly progressive weightlifting compared with no exercise did not result in any increase in the lymphedema. As a matter of fact, additional meta-analysis of aerobic and resistance exercises supports the benefit of exercise in at-risk and affected survivors. So that's important. The other is it safe to travel by air after axillary surgery? Although many clinicians have advocated wearing a prophylactic compression garment on planes, some data suggest this may be actually counterproductive. In various studies on the effect of air travel on lymphedema risk in women with history of breast cancer, which used bioimpedance surveillance for lymphedema, the authors concluded that air travel did not affect bioimpedance values in 95% of at-risk women. Therefore, air travels is very unlikely to impact lymphedema. Can women uh, shave under their arms after the axillary surgery? There are anecdotal advice regarding the use of electric razors rather than other manual razors, but this is based on old and unfounded evidence related to trauma following axillary lymph node dissection. There seems no reason to advise women that they cannot shave axillary hair following an axillary surgery. If sensation is altered in the axilla, it is important that shaving be done in front of a mirror to avoid any unreasonable trauma or injury. Can patients have blood pressure measured in the treated arm? And this is one of the most commonly asked question and most commonly given advice not to do so. However, what does the evidence say? Although the blood pressure can cause temporary stasis of blood, but there's no clear evidence that suggests that it can cause a prolonged lymphedema. As a matter of fact, there is a study published in Journal of Clinical Oncology, which is the official journal of American Society of Clinical Oncology, and this was in 2016, where they looked at the role of ipsilated blood draws, injections, and blood pressures and air travel also. And it did conclude that that blood pressure measurement did not increase the lymphedema incidence. So women should be advised that there is no reason they cannot have their blood pressure measured in the arm on the side of axillary surgery. Can patients have blood test or intravenous cannulation or immunization in the treated arm? Of course, any puncture can act as an entry point for infection, but in general, in non-immunocompromised population and following a breast cancer surgery, the patients generally regain their normal immunity in 6 months to 1 year time. The risk in a non-immunocompromised population is minimal. As a matter of fact, there are a lot of studies on it. The breast cancer related lymphedema after venipuncture a review of evidence-based recommendations says that venipuncture should be performed on the contralateral arm preferably, but if that is not readily available, in the absence of lymphedema, it is preferable to consider venipuncture in the ipsilateral arm, that is the arm on which, or the side in which the operation has been done. And insertion of central venous devices, although should be avoided in the in the ipsilateral arm, that is peripherally inserted central lines, but it is not a good idea to put a cannulation in the vein. In the absence of lymphedema, a venesection on the ipsilateral arm carries very little risk, if any, or any risk of additional complication is minimal. Retrospective studies have evaluated the link between skin puncture, lymphedema, and generally they are confounded by recall bias. That means those studies which actually highlighted that this can increase lymphedema is actually confounded by recall bias, because when patients try to recall, they think that this has perhaps been precipitated by a venipuncture, which is generally a recall bias. As a matter of fact, again, the same study actually which looked at blood pressure measurement, also looked at blood draws and injections and immunizations, and they did not find any difference or any increase in the lymphedema incidence. If you look at these forest plots, the point estimates are absolutely on the unity line. As a matter of fact, it is only trauma which may increase the lymphedema, and significant trauma, and cellulitis. Cellulitis is significant infection of the skin. Those things which can increase lymphedema chances are high body mass index, axillary lymph node dissection, and cellulitis. These are the variables which can increase the lymphedema, but not the flying hours or the flight time or blood pressure management, blood pressure measurement, or injections or blood draws. These do not increase the chance of lymphedema. Can patients take intravenous fluids in the treated arm? Providing there is a well-placed cannula in a moderately sized vein, there's no obvious fluid extravasation, there should not be any concern about giving intravenous fluids in the arm where sentinel lymph node biopsy is done. A peripherally inserted central venous catheter should be avoided because that carries greater risk of infection and venous thrombosis. And the same guidelines hold over here, that if the contralateral arm cannot be used, one can take on to the ipsilateral arm, and in the absence of lymphedema, and any additional risk is very, very minimal. Can women go for sauna after axillary surgery? The sub-analysis of the physical activity and lymphedema trial, which I discussed upfront, says that sauna may more likely, patients using sauna may more likely develop lymphedema, and this is an area where overall evidence base is very limited. But at least for now, women should be warned to avoid sauna until there is more evidence of how this particular thing influence arm swelling. Does weight reduction help improve lymphedema? Yes, absolutely. Obesity and elevated body weight have been consistently shown to influence arm swelling and risk. Obesity is known to impair lymphatic drainage, and impaired drainage can precipitate lymphedema. As I had already highlighted earlier, a body mass index of more than 25 increases the chance of lymphedema. Is limb elevation helpful? So there is no evidence that this is beneficial. Arm elevation has little effect on long-term lymphedema. This may be due to the relatively higher oncotic pressure of lymphatic fluid compartment and as compared to the venous fluid. So venous swelling may be helped, but limb elevation and lymphedema may not be helped by arm elevation. So what advice are we going to give to those undergoing bilateral procedures? So there was a large study which was again published in Journal of Clinical Oncology in 2017, and around 10 to 20% women who are diagnosed with breast cancer may require bilateral surgeries, either as a risk reduction surgery or because of bilateral tumors. And this causes significant anxiety in patients. So in this particular study, again, the association between precautionary behaviors and breast cancer related lymphedema in patients undergoing bilateral surgeries, the study did not find any difference as far as blood pressure measurement is concerned, blood draw is concerned, injections on the side of surgery is concerned, major or minor trauma is concerned, or flying time or number of flights taken per year is concerned. You can see that the point estimates are around the unity line, and the 95% confidence intervals are crossing the unity line. What matters is a high body mass index, an axillary lymph node dissection, maybe some chemotherapy, and radiation to the chest wall may or may not actually increase the chance of lymphedema. So these patients can very well take blood pressure monitoring and can also do minor injections or subcutaneous injection on the same arm. As per evidence in literature, there is no increase in lymphedema. So the study concluded that blood pressure readings, blood draws, injections, and number of duration of flights were not significantly associated with increase in arm volume in this particular cohort. So if I were to conclude, patients in general overestimate their risk of developing lymphedema, with 75% of axillary lymph node dissection and 50% of sentinel lymph node biopsy patients worrying about this particular problem. Patients definitely needs to be counseled that lymphedema is unpredictable, and if it does develop, it can be quite permanent. So it is important to educate patients regarding the risk, which is very critical, but it is also very important that to increase their anxiety or to give advice that is not evidence-based is absolutely unwarranted. Thank you very much, and over to the organizers.
Thank you, Dr. Manish. These were very, very interesting conclusions that you have shared with us. I'm sure there will be several questions which I will share with you.